What's up, everybody? Dr. Michael Mash here with Barbell Rehab, sitting here with Dr. Miles Nicholas, where we today, during this Pain Points series video, are going to talk about frozen shoulder, aka adhesive capsulitis. Reason why we're filming this video is when I taught the last Barbell Rehab Method course in Kansas City, or rather Olathe, Kansas, at ROKC Olathe. Great course, met some awesome people there. One of the strength coaches there asked a question of how do I manage clients that have frozen shoulder? So I thought it would be a great opportunity to talk about the latest evidence about frozen shoulder, what it is, why it happens, and how to really manage it on this spectrum of rehab to performance. So let's start out the video with Dr. Miles. Why don't you give us just an overview of what exactly is frozen shoulder? What would a patient that has frozen shoulder present like, and what's the natural history of it?
Okay. So frozen shoulder, or adhesive capsulitis, is a condition of the shoulder that we don't perfectly understand, but we have enough working knowledge of how to manage it. So in terms of like the etiology, we know that there's some component of capsular irritation, metabolic processes, the synovium around the joint, same thing. We also know that muscle guarding and pain are a very big part of it. One of my favorite studies in terms of anything frozen shoulder related talks about people with diagnosed frozen shoulder being put under anesthesia and looking at the massive increases we see in elevation and external rotation range of motion. So in terms of how we diagnose it, the things that we look for are pain that's been around for around a month or more. We look for symptoms at night, a generalized achiness, and then from there we look for limitations in external rotation, both actively, meaning what I can do, and also passively what someone else can do. And then furthermore, that's going to be in multiple ranges, and then also elevation, both actively and passively. So that's what we look for. In terms of, Mike said, natural course of history. So it was believed historically that this was a completely self-limiting condition, meaning that it comes on, it runs its course, which in this case can be 15, 18, 20, 24 months, a very long time. But by the end of it, someone's back to baseline. And what we've seen in the research is that people don't fully return to baseline in terms of pain and range of motion, but disability isn't super high. I've seen 40% of participants still have some disability. I've seen a very low number, like 10%. So there's some range there. But when it comes down to it, this is a condition that we tend to see more in women in terms of middle age, like 40 to 60, 65. We see a high prevalence in what we call systemic secondary frozen shoulder, so diabetes and thyroid disorders. Other types of secondary frozen shoulder would be intrinsic or extrinsic. So intrinsic meaning that something has been going on with that shoulder and then that develops into a painful stiff shoulder. Extrinsic meaning that something else in the body happened. It could be a fracture of the hand, it could be someone having a stroke, and that leads to this restricted painful shoulder. And then we have primary idiopathic frozen shoulder, which does not have a specific cause that we can pinpoint, but it comes on kind of out of nowhere. We can't really predict it, and then we have to manage it. So that's kind of your generalized baseline. The only other thing is that in general we talk about stages, and it's kind of stage one, which is we'll call it like pre-freezing, and some people don't like to use these terms, and I'm fine with that. Then you have stage two, where it's theoretically freezing and pain is getting higher and we're starting to lose more and more range of motion. You have the quote-unquote stage three, or frozen stage, where pain and range of motion are both quite functionally limiting. And then finally, the last stage, the thawing stage, is kind of, we'll call it around 12, 15 months until it's gone, theoretically, right? Where the person is little by little moving back towards baseline.
And I think something important that you touched on, and we can extrapolate into other types of pain situations, is we don't know what exactly causes this.
Yeah.
And that's okay, because we don't need to know exactly, you don't need to know the exact reason in order to effectively manage it.
Right.
And that goes with other things. Like if you're dealing with somebody that has shoulder pain, we don't need to know the exact anatomical diagnosis to accurately treat it, to accurately apply the principles of load management.
Right.
And that was something that came up in the course where people were asking me, well, what causes it? What causes it? And I'm
Right.
like, I think we're asking the wrong questions.
Right.
It's more or less of, because I think where they're coming from is if we know what causes it,
Then we would treat it in a specific fashion,
Or,
and it would give a specific, yes.
or even better, if we knew what causes it, then we can do things to prevent it from happening 100%, right? If we knew the exact cause, then we can just prevent it. But I think those are asking the wrong questions. The right questions are, how do we mitigate the effects of it, and how do we accurately prescribe exercise, both aerobic strength training and stretching work for situations like this. So now knowing that it is most of the time a longer situation, this goes into what we're going to talk about in this video is what's the role of the personal trainer or the strength coach for somebody that has adhesive capsulitis. Ideally, if a client or a patient has functional limitations and unable to reach their goals, even after a year, they would still be in physical therapy. But the reality of it is, due to continually lowering reimbursement rates, the way insurances work, not a lot of people can go to physical therapy for weeks and weeks and weeks and months. So let's assume the typical situation being this person goes to physical therapy most of the time when it gets bad enough that it warrants somebody's help. So they go to physical therapy. Maybe they're seen, let's say they're seen for a 2-month plan of care. And we as the physical therapist get them to a point that the best we can do in 2 months, but guess what? They're still leaving with functional limitations, range of motion limitations, higher level goals unattained. Maybe we get them to the point where they can go through their daily life decently using that shoulder, but unable to, they still have range of motion limitations. They still have low level pain. Are we just going to send them home and tell them to wing it?
Yeah.
No, we want to empower. You said
Not yet. Acknowledging what you said, but disagreeing. Yeah.
We want to empower fitness professionals to teach them how to manage maybe the mid to later phases of this.
Yeah,
so let's take a situation of somebody that's 8 months out of
the onset of pain.
Yeah, the onset of pain. That was, thanks for finishing. Yeah, let's 8 months after the onset of pain, let's say that they were in physical therapy for 8 months, which is, that's like an ideal situation these days, having somebody in for that long. Let's say they come into the personal trainer and they tell the personal trainer, hey, I was just in physical therapy for 8 months for frozen shoulder. I'd like to continue my exercise. I would like to continue to take my exercises to the next level. Can you help me? And this personal trainer says, heck yeah, like I know barbell rehab. Like I follow barbell rehab. They help me all the time with learning how to manage clients that have had pain or mobility limitations. So heck yeah, I can help you. Anyways, after that tangent. So what advice can we give for a personal trainer that is working with somebody 7 to 8 months out of onset of pain for adhesive capsulitis?
Yeah, so I guess I would look at it at a localized level and a global level, right? So when you look at the individual in front of you, I would say that's a heck of a time to work on their aerobic conditioning, lower body training, trunk training, all that stuff. And then when it comes to where the shoulder is at, what they can do with their upper body, it's going to depend upon the way they present. If they come in, say it's 8 months out, and they're still limited in external rotation and overhead mobility, you're probably not doing a barbell overhead press. You're probably not doing maybe even a landmine press. Yeah. But there are things that we can do in terms of, one, kind of helping continue that plan of care that the physical therapist was running, hopefully with good collaboration. So it could be working on overhead dowel flexion, maybe with a 5-pound plate over it. It could be doing some stick external rotation, or as Mike loves, eccentric internal rotation of the shoulder, but still doing the kind of stuff that they were doing in physical therapy, working on these range of motion limitations to the person's tolerance based upon how irritable their shoulder is.
Yeah, so that's a really good point. And we always talk about this collaboration. Ideally, the strength coach, personal trainer can just call up the physio and be like, hey, like, Give me anything you can give me on this person to help me take them the next step would be beneficial. But as we know, not always feasible.
Right.
So in situations like this, and this goes outside of just frozen shoulder, I like to ask, if I'm the strength coach, I would ask that client, what kind of things were you doing in physical therapy? Like, what kind of things were you doing? So you get a baseline understanding of where they're at.
Yeah.
Like, maybe if they were not at such a good PT, they just say, oh yeah, I just moved this stick around for eight months,
Right.
or the person just stretched my shoulder until I was in tears for 8 months, right? So you need to somehow find out whether it's asking the client themselves or calling or emailing, texting, whatever we do.
Yep.
TikToking, whatever. I'm just kidding. The physical therapist to figure out what this client was doing. So as he mentioned, you're going to see mainly limitations in reaching overhead, both passively and actively, and externally rotating. So at 7 months, there is still, as the personal trainer or strength coach, you're going to want to include some form of stretching, whether it's pure static stretching, whether it's stretching with a little bit of load. Pure static stretching would be, with that stick, you can add a 5-pound weight to it to help improve flexion. Other exercises like just a pure stick ER, or like Dr. Miles mentioned, an eccentric internal rotation with a dumbbell to just slowly restore that range of motion. Right. But the one thing I really want to specify here is it should be done to the client's tolerance.
Yeah.
When I was in clinical, rotation, a couple of them, and this is by no means to knock. If you're more of a veteran physical therapist watching this video, this is by no means to knock veteran physical therapists. It's just the older way to treat this was to crank on these shoulders. And there is enough evidence to show that we don't need to put people through torturous stretching in order to see range of motion improvements.
Right.
So this is not a thing that's happening just by older clinicians.
And that's especially because, like we talked about, like this is a muscle guarding, this is a pain. Like some of this range of motion is limited not by like the joint, but by pain and guarding.
Yeah, so what's going to happen if you grab somebody's shoulder and just crank on it? They're just going to fight back until they eventually just say, I am tired of fighting back, I'm just going to let them take it.
Right.
And next thing you know, it's excruciating pain for how many days, who knows. So big picture, when you're going to do stretching for somebody that has adhesive capsulitis, or anything for that matter, it doesn't need to be overly aggressive. So I would be restoring flexion, abduction, scaption, and external rotation, and then finding an entry point of where we can strength train.
Yeah. What are some good loading options?
So some great loading options are, you're most likely going to be just fine to do horizontal pushing and pulling patterns, right? Let's assume at 7-8 months they have 110-20 degrees of flexion, both passive and active. Right. We can still do push-up variations, even if it's inclined on a barbell.
Yeah, 100%.
We can definitely do horizontal rowing variations. You can definitely do bis and tris. Anything that's really not, I would not be strict pressing this person quite yet. I might not even be landmine pressing, depending on the irritability and the available range of motion.
Because 8 months is still, it could be early enough on that they're not quite ready for it.
So I might not be landmine pressing them, but I would be doing my horizontal pulling, pushing, biceps, triceps, layering that in with some of the static stretching. And once a supine 1 flexion starts to get challenging, or once the client has been doing that for a while, I might layer in an eccentric lat pull down, where we're not using it primarily to increase lat strength, but primarily to increase range of motion. Where, let's say I'm dealing with frozen shoulder on my right shoulder, I might be able to get my arm up to that lat pull down machine and just let that lat pull down machine take me into as much comfortable, tolerable flexion that it can, and then pull back down. So I'd be doing nice slow reps. It's almost like a loaded pulley when it really comes down to it. And a great way to give the client the locus of control. Right. And you just tell the client, go as far that you feel comfortable, versus me grabbing it and seeing how hard I can stretch it. Yeah. So those are all great options. I have one question for you, but anything to piggyback off of that?
No.
Okay, so usually when I teach these courses, and I get this question all the time, and once you start teaching more courses, you're going to inevitably get it as well. Somebody will say, well, the shoulder's already tight. why are we going to do any strengthening to it?
Right.
It should be all stretching, because if we start to add strengthening of the shoulder on top of something that's already tight, won't it make it tighter?
Right. Yeah. So I'll go right to the point on this one, because we have a good amount of evidence that shows that strength training, loaded exercise and movement through as much of full range of motion as someone has, or full range of motion, is just as effective at gaining range of motion as static stretching.
Yep.
So I'm fine with people using both, but I think it's really important that people realize that doing, like you mentioned, something that looks maybe like an eccentric lat pull down, utilizing that to work on range of motion is going to be just as effective as doing a static stretch. And if someone's at the point where they can tolerate it, then we also get the benefits of strengthening.
Yep. Trust us, we're doctors.
Yes.
Anyways, yeah, so that pretty much wraps up my thoughts on frozen shoulder. As with anything, it really comes down to, on that day one, you're working with that client. How do they move? What positions are tolerable? Which positions are not tolerable? Mm-hmm. What have they done? Gather all of this information, strength train within the available range of motion, lightly strength train into
the restrictions,
while also layering in some static stretching when appropriate. And I think you need to set the expectation that, hey, this thing is not going to get better in 2 days, right? We need to help the client understand the expectation.
Reassure them, be there for them.
Yeah, reassure them that this is normal. It's normal to still be feeling like this 7-8 months out, so that they don't go down this rabbit hole of catastrophizing and all that fun stuff. Be there for them, listen to them, and yeah, I think that pretty much covers it. So hopefully, if you're a strength coach or physical therapist, or anybody listening to this that works with clients that may be dealing with frozen shoulder, hopefully this gives you a better approach to managing it. So hopefully you enjoyed this video of our pain points series, and come back next time and we'll see you for the next video.